Good morning and welcome to the Friday morning lecture series. We're here live at Hollow Casino. Had a nice little incident already. So otherwise everything is going well. No, it's not dealing with behavioral emergencies unless we're discussing with some of the EMS personnel. But otherwise we're doing pretty good. Everyone's good? Everyone good this morning? All right. Behavioral emergencies. I'm Dr. Dana Shreen, Friday morning, Hollow Casino. Uh, Pretty much throughout the rest of the theme of the topic, it's really this. Just be Darth Vader, however you want to do it. Yeah, yeah. Pass the donuts around if you guys want some. Yeah, I can't do the voice. All right. Just as a reminder, why disclaimer, had to have a disclaimer for the day. Pretty much, you guys, extension of the physician, everything that we do, say, and all that stuff, going down that path. And then, like I said, it's more importantly, number two, um, I have my life on there, but usually I change that over. It's the life of my kids that's more important now than me. So I want you guys to be able to save them. All right. So definitions: behavioral versus psychiatric emergencies. Behavioral is just something that interferes with the activities of daily living. So things like paranoia, depression, that those aspects, where they have to if they have have to check the locks because they're obsessive compulsive, they're cleaning, versus the psychiatric where there's a potential life injury, life threat, either to themselves and or to somebody else. So it's when we talk about Terrasos in a little bit, that whole thing of our duty to notify and duty to act comes into play because of what's happened. So psychiatrics, okay, anything that's disturbing to himself, his family, or his community. We see most uh, the kind of sort of the unwritten rule. Anything that comes into the emergency room, there's a 90% component of some psychiatric issue going on. You come in with a stub toe, there's probably something psychiatric involved with that. So it's there. But for what we're our purposes and all that stuff, really going down the what type of interventions that we have to deal with. So think about it. What is the most common psychiatric quote unquote condition there is? It's up there. What? Depression, anxiety. Yep, anxiety is the most common. It's just everyone kind of sort of has some piece of it, and it actually depends on different stages of our life and all that stuff. So anxiety, phobias, depression, psychosis, suicides, previous, and we'll talk about a little bit of substance abuse and all that stuff, but not a lot. Right? Anything, from the perspective of the, ETU, expect the unexpected when it comes to psychiatric, patients. But what exactly caused the behavior and all that stuff could be a number of things, from drugs, alcohols, previous conditions, illnesses, even trauma when we deal with, PTSD, or some of those other related conditions. On the behavioral, really, it's going to be broken down into the four different pieces. So when we're looking at behavioral changes or behavioral reasons for them to have a potential psychiatric or what we deem as a psychiatric breakthrough or something like that. Uh, One of the first things, if we think about it, is someone that has a behavioral change and they're known schizophrenic, but they have something changed. What should we always get on these people? Two things: blood sugar's one, and chemical balance. But can you check for chemical imbalances? Okay, but what can you guys check? Blood pressure. Okay, yeah. Oxygen. Get your oxygen level. Okay, so are they hypoxic or are they hypoglycemic? Those are really the two huge things that for someone, even if they are a known psychiatric patient, if they have an acute change, those can potentially, especially with head traumas and stuff like that. So other things, the blood flow problems, if they're taking drugs, if we have to give them some, if they have acute change and we got to give them some naloxone or something like that. So the four pieces, the biologic is one of them, or the organic. Is there something that has happened? Okay. Did they have a heart attack, several months ago, and now they're having low blood pressure, so now they're having CHF problems? Are they getting just old and they have Alzheimer's disease? Some of the weird degenerative diseases, with the multiple sclerosis can sometimes cause Lou Gehrig's disease. The do they have I'm blanking on the other one right now. So infections, of course, if they're meningitis and encephalitis. Okay, so what's the issue all the time on the airplanes of the couple of individuals that have been recently? They've had acute psychotic breakthroughs and they're, you know, had an infections and all that stuff that's going. So that's always a piece. Environmental. Okay. We know that stress is a very leading cause for everything, especially when the dealing with the anxiety, PTSD, even stress leading to some of the um, your psychotic breakthroughs because they just can't handle anything anymore. And then any of the sociologic factors involved. Injuries and illnesses, patients if they're reliving, okay, the stressful situations, the flashbacks we'll talk about a little bit, and then just closed head injuries themselves, how they can have different related stuff. So what's the second victim syndrome for EMS providers? Anyone ever heard of this? Correct. All right, so it is. So we're introduced, and then we feel that we should have done something differently to change that person or that outcome. So we keep reliving it and reliving it and reliving it, and then we become the quote unquote the victim. So, yep. Substances abuses. I mean, we all know that. What does methamphetamine do to people? What does continued heroin and all that stuff do to people? And then drugs and alcohol. So looking at clues, okay, some of the stuff, it might not be an acute thing. I mean, some of it might be a sudden onset. Do they have abnormal breath? When we think of someone that's diabetic, and they're altered and they're fighting, and they're combative, what do you think of? DKA, okay. But what does the breath? Okay, the fruity breath, the acidic breath. Okay, yep. So, well, no, correct. Yep, all that stuff. Which I can't smell ketones. Some people can smell the ketones. So, are they having excessive salivation? Did they get some organophosphate poisoning or something like that? Are they pupils abnormal if they have a Narcan or if they need something like that? So the mental disorders, all right, really it's broken down into six, seven, depending on how many who you talk to, DSM-5 criteria, related categories. All right, so we'll hit through some of this, and for the most part, understanding what it is. Really, again, from the aspect, anxiety is the most common, but we see a lot of mood disorders. Schizophrenia, even though we see it a lot in the emergency room, it's really not that prevalent of a disease. And it is, all these are diseases. Okay, so the unfortunate is, I mean, these are chronic diseases that just not well managed for a number of individuals. Okay, anxiety, again, it's that fear, the restlessness. They just, what do we see when someone comes in? They're having an anxiety attack. Breath, shaking, breathing fast, sweating. Okay, some might have some paranoia involved with all that stuff. Okay, and then general anxiety disorder. This is a very treatable. A lot of it's treating it with some of the antidepressant medications that will put them on Zoloft and stuff like that. The SSRIs. Uh, but really, the general anxiety disorders is they worry about anything and everything. I mean, there could be, a shooting in Greece and they're worried about it. Oh, what about the family? And so, yeah, I know you don't. Uh, But the impending problems versus the panic attack. This is the bad side of the anxiety disorders that we deal with. All right, agitation and anxiety and all that stuff. The intense fears. What's the most common complaint that they have, and what brings them to the emergency room? They're having chest pains. Okay, so often they're complaining of the chest pains, the palpitations, and all that stuff. Yep, thinking they have a heart attack. So what? And you might not know this. What physical condition do people have? Usually more females that can actually cause panic attacks and anxiety. What heart condition? I know this is what is the doctor thinking right now? Okay. Mitral valve prolapse. Yep. So females that have mitral valve prolapse regurg, okay, because again the valves are going backwards and it keeps hitting, and then they develop over time a little bit of anxiety disorder and all that stuff. So food for that. Agoraphobia is the fear of going to public places, and we'll talk about more of that in a little bit. So what are we signs and symptoms? The diarrhea, the palpitations, the tremors. They just don't feel well. They may be diaphoretic. They could have irregular heartbeat, even on monitors. They could be tachycardic. So what questions do we want to ask? Anything recently changed? Dun, 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 dun. Drug and alcohol use. Come on, boys. Time to participate. General history. Okay. Cardiac history, all that stuff. All right. Changing medications. Are they taking anything? Did they have anything? Stop taking medications. Okay. And one of the other things too to ask about the panic attacks and anxiety is what happened a year ago. Okay. Is there a? Do they have? Are they getting close to an anniversary? Correct. Okay. Did they have their father died? And we see this a lot of times. Oh, my father died, 2 years ago at this place at this time, and I drove by it, or stuff like that. As us as EMS providers, we can drive by a certain spot and we know what that happened at that spot at that time, and all, depending. All right. Phobias, intense fears. Okay. We all have some phobia. It doesn't matter. It's just a matter of figuring it out. Okay. The most top four. This is just the top four list of Dave Lemon, whatever. Okay. Arachnophobia, fear of spiders, 50% women, 10% men. Ophidiophobia, fear of the snakes. Story with my mother when we first moved to South Carolina. She was outside, and it was like 30, 45 minutes later. My dad's like going, "Where's mom?" And I was like 9 years old. I'm like going, "I don't know." So we go outside, and there was literally a foot long gardener snake, and they were eye to eye to each other. Neither one would move. So my mom hates snakes. Agoraphobia, fear of heights, and then agoraphobia, of course, is the fear of specific places and situations and all that stuff. They do have down at you guys can't see it on there, www.fearof.net, and it'll give you your top 100, which is, I mean, you could have fear of ducks and fear of everything. Fear, yeah. Finishing up, rounding it out, post traumatic stress disorder. Okay, this is the chronic portion of anxiety or chronic portion of the panic attack. A lot of it was the flashbacks. The unfortunate are military vets and all that stuff. A lot of things that they see. We in the EMS, okay, we have the same type problems. At times we'll get flashbacks, and depending on all that stuff. Um, Definition or diagnosis begin within 6 months, and then recollections last greater than a month, but again within 6 months. Frequent unwanted memories, and then from there you have to have it has to have some debilitating, and you're thinking about it. It's like 3 or 4 times a week. I mean, so it has pieces and all that stuff for the actual DSM-5 criteria. Yeah. Yep. I had a lot of friends on that Death Star. Yeah. So depression, actually, the mood disorders, okay, broken down into two general ideas. So the question is this a unipolar or a bipolar? Okay, is when it comes to the mood disorders. The unipolars, there's two situations with unipolars: the manic versus the depressive, and then of course the bipolar. What do you think of if they're bipolar? What? Chronic up and down. So it's both a combination of manic and depressant. Hey, okay. So we're good there. So, form of unipolar. This is your precious speech, tangential thoughts, grandiose, unrealistic ideas. Okay. Have we not seen this here at the casino? Who has not seen this yet? Okay. And this is again from the perspective of a lot of, if they're manic, they do frequent places like the casinos, a lot of the strip clubs and all that stuff. So just something to take into place. Versus depression, again, another form of the unipolar. It's the exact opposites, the feeling sadness, worthless discouragement. Okay. And then it's one of the factors in suicides and all that stuff. So when we think of depression, what do we want to ask? What? If they're either suicidal, what? Want to hurt themselves, hurt others, withdrawals from what? Alcohol. Okay. Drugs, medications. Anything else? All right. So the mnemonic that I was taught way back when is Siggy Caps. There's a couple other ones in the EMS world and arena, all that stuff. So are they sleeping more or less? Okay. Are they having lack of interest? Okay. Which the term is anhedonia. That's the lack of interest. And we see anhedonia a lot with the schizophrenics. Are they having guilt? Guilt for, sometimes from the perspective of, they're still alive. They have a loved one that died. Guilt of whatever reasons, something that they did in their past. Fatigue, concentration problems. They just can't think of anything. Concentration used a lot of times used to be one of the kind of sort of the starting pieces. It was sleep, and then from there I have the lack of appetite, or are they eating everything in the house? Could be flip sides and all that stuff. Slowing psychomotor, and then suicidal thoughts and all that stuff. That rounds up the C caps. And of course, all the other stuff. Are they crying? Are they withdrawing? Okay. So for us, okay, one of the things that we have to ask is, do you want to kill yourself? Flat up. Okay. Does not always mean that they're going to do it, but we have to ask. Right? If they say yes, I want to kill myself. Okay. What do we do? Bring, bring them to me. Yes. Okay. Other places that we can take them to: rescue crisis, behavioral health. Okay. So all that stuff. Uh, Asking the question, hey, do you want to kill yourself? It does not put the idea in their head. Okay. Um, if they are going to kill themselves, they're already going to kill themselves. So if they have a plan, any intents or anything like that, then pretty much, they're going to, we have to make sure that we take anything that's suicidal, even you're going, yeah, whatever. You said this now the 15th time, which we have a lot of patients that come in. Because they know if they say that I'm suicidal, they get a couple days in the hospital, and if you're depending on your living conditions and all that stuff. It goes from there. So at times, this is actually a willful act designed to end one's life. It's illegal in the state of Ohio to kill yourself. Yep. Um, Second, among college students, women more often will attempt it, and then men are more successful at it. Okay. Most common cause for women killing themselves. What do they do? Pills. Okay. For men, shootings, hangings. Okay. Yep. Yep. So men, and that's why men. Okay. So age or what is the typical prototypic person that kills themselves? Okay. Over 40. Okay. So over 40, what race? White. Okay. In America. Yes, males. And usually what has happened? Yep. So all that accumulation, all that stuff. Okay. 50% of pre-use is attempted. 75% will have no clear intent or warning. Alcohol may or may not be involved. Can neither confirm or deny anything with that. Okay. And then, of course, people kill themselves, do talk about it in advance. The question is for us, do we pick up on those subtle hints? Just from the aspect of, hey, here's my favorite, fuzzy dice. Or, just, that one piece. Nope. Yep. Nope. So risk factors, of course. Recently, again, from the aspect we talked about this: divorce, widowed, drug, alcohol, previous depression, suicide attempts. Okay, if they said, "Yeah, I've tried shooting myself in the past," that's yeah. Do you have access to a gun? Yes, I do. Okay. Okay. And then any current diagnoses. So one of the questions that I always ask individuals when it goes down, really the aspect of, how much of it, and I don't know if this is legit or anything like that. Um, the Asking the question, so if I discharge you today, what are you going to do when you go home? If they're like going, well, I'm going to go find that rope and all that stuff, or well, I'm just going to go home and call my loved one, my family. So you can actually, even those simple things, kind of sort of gives a judge as to what we do and all that stuff. Teens, okay, teen suicide is up, okay. Um, 2007 to 2014, it's doubled. So a huge piece. So yes, really from the perspective of teens, that it's has actually you know passed car accidents and traumas and all that stuff. So a huge thing. Violence. Right? 67% of behavioral emergency patients become assaultive or violent. Okay. We work in this industry. Unfortunately, that is what it is. This is why, for a number of the agencies, we're actually including ketamine into one of our armamentariums now. So put the patient down that becomes violent, very quick acting, and we'll talk more later on that. So causes. Okay. Are they psychotic? Do they have fears? Do they have panics? Okay. Do they just irrational and all that stuff? Okay. Yeah. Not clowns. You're not a clown person? Okay. That's a mean clown too. Right. Warning signs. Okay. Again, very similar to depression and suicide. They will have stuff. So what's one of the first things that we start seeing? Restlessness, change in behavior. When they're going to become violent, what do they start? Okay, so they can get quiet, okay, intense, or what do they do? How does their speech starts getting a little bit faster and a little bit louder, and then a little bit louder, then a little bit louder? So, or yes, or they withdraw back, they don't say anything, and then they start doing the pacing and all that stuff. Okay. And always look at their hands. Okay. From a martial arts standpoint, that's one of the things to always look at someone's hands and all that stuff. Because once their hands start culling up, then it's going to be a bad day. So Tarasov on this 1976 unfortunate incident, but really changed our part of our duties and responsibilities and all that stuff. Okay, so 40 years ago, this young lady unfortunately was killed because she didn't want to um, go out with an individual. At the time, that individual was under treatment by a psychiatrist. He kind of sort of knew that. The person actually had made comments even in the psychiatrist notes when they went back and looking at all the information. It was clearly laid out. They called the police. They said, "Hey, yep, you have this individual." The police stopped by and looked at him, said, "Okay, no problem. So we're going to contract you. Don't see her. Don't go near her." Of course, yes. 2 minutes later, he kills her, and that's where we go. The family went to sue California Health Department, all that stuff. Was dismissed. They took it, of course, like everything else, to the Supreme Court, and that's where the Supreme Court says, unfortunately, not we, the psychiatrists have a duty to warn. Since then, throughout the majority of every state, there's some law that has been adopted and all that stuff. So for us, it's in the administrative code on duty to warns and all that stuff. Sometimes, if you think about it, it's we are the only people as EMS providers because if all patients seem to like the EMS. They will talk to us. They won't talk to anybody else, and they will give you clues of who the individual, or if you can find out, ask those sort of things. Okay. We have a duty to warn. Tell the nurses they have a duty to warn. Tell the doctor they have a duty to warn. Okay? So everybody should be telling. Go from there. The flip side of it is going to be your bipolar. Okay, so we have the unipolar versus the bipolar. Okay, the bipolar is not mood swings from minute to minute. Okay, that's actually when we talk about borderline personality disorder, that's more of what that is. So the bipolar is they go from one grandiosis and all that stuff, and then they lose all their money, then they sink into depression. Oh, next month I get some more money again, so I become manic, and then go back and forth. Okay, a lot of good treatment options, psychotherapies, electric shock therapy. There's a number of pieces and all that stuff for that. Yeah. So our personality disorders. Okay, really, it's broken up into three categories. So you have the odd behaviors versus the dramatic, which is the category B. So you have category A or the cluster A, cluster B, and then the cluster C, which is the anxious. And then inside the odd behaviors, this is your paranoid, the schizoid, or the schizotypal. In the dramatics, it's your antisocials, the borderlines, the histrionics, and narcissistics. And that's the borderline personality disorder is the one that a lot of times they flip on you and you know, but the BSC, they become the batshit crazy and all that stuff. All right. Or the anxiousness, the avoidant, dependent, obsessive compulsive. So paranoid personality, okay, just from the aspect they worry about everything. Some of the questions, what do you want to think about with this? What do you want to ask? Okay, say it. Yes. Why do you think someone's after them? Do they see, is someone following them? All that stuff. Okay. And then from there, is this do they have chronic conditions? Individuals, dementia, all that stuff. They will develop paranoid tendencies and all that stuff. Do they have other psychiatric conditions? Medication changes, all that stuff. Drug and alcohol? Never. Never. No. All right. Schizoid, this is a tendency to direct attention towards one's inner life and away from the external world. These are just the odd people. You see them like going, yep, they're, a lot of times they don't want any social, they just, you see them, they're odd. Um, Not bad or anything. Versus the schizotypal, this is, they actually feel a little bit more uncomfortable in the situation. They don't want to be there. Versus the schizoid, they're like, going, okay, I can do this, but they would rather be off by themselves and all that stuff. Individuals with schizotypal, they have a possibility of actually developing into schizophrenia. So there's some pieces and all that stuff. So with schizotypals, they have reduced capacity, anything with relationships. They have distorted cognitions. They can have pieces of paranoia involved with that. So you can actually have, the multiple personality disorders pieced together for what it's worth. Versus your antisocial, okay? They just don't like anything. They don't care, okay? There's some thought premises that you can actually, your ODDs, the oppositional defiant disorder, so more in the kids and all that stuff. There's some that say maybe this leads into antisocial personality disorders for what it's worth. Or they're just kids that, having bad days. They don't care about the rights. They lack consciousness, empathy. Males, like most things, males are more. It's more prevalent in males versus females. Um, and then, of course, it's that bottom piece. This is the mental disorder, just most closely correlated with crime. So a lot of your acute psychopaths and all that stuff, they have a piece of an antisocial disorder. Borderline. Okay. These are the individuals. Ooh, I love you, I love you, I love you. Ooh, I hate you, I hate you, I hate you. Ooh, I love you, I love you, I love you. Ooh, I hate you, I hate you, I hate you. Okay. They go back and forth in impulsivity, mood swings, quickly, extreme fluctuations. One minute you're your best friend, the next minute they want to stab you with the steak knife. Okay. Rapid changes, but it's really they have the instability and the hypersensitivity in interpersonal relationships. And it got its name borderline because it was, the aspect of it was between a couple different other personality disorders. This is histrionics. Okay, we've never seen anyone like this in a high school. Okay. They want to be the center of attention. They will do anything and everything to become the center of the attention. And when they're not the center of attention, okay, then they become depressed and withdrawn. And yeah, exactly. Okay. Um, and they're very superficial, insincere. They just don't care about anything but themselves. Versus the narcissistic, okay. Um, Beauty and the Beast cartoon, just got it, okay. Gaston, sitting there in the mirror, cleaning out his teeth, okay. That's a classic narcissistic for you. They want, unconditionally being admired, and they feel entitled, and you know, he thought he should have Bell and didn't matter, and go from there. Okay. Versus your avoidant. Okay. Charlie Brown gonna kick the football. Well, maybe, maybe not. Throw the baseball. Well, I don't know if I want to. Just because they want to have the aspect of the social. They feel, the aspect of rejection and criticism and all that stuff. This is one where it's more common in women versus men. And then, of course, with the anxiety, they become anxious in the situations. Dependent, okay. Excess need to be taken care of, leading to submissive and clingy behaviors. So there's a piece is with the dependent is that actually also joined into with the borderline. Okay, so there's some crossbreeding with the borderline personality disorder with dependents. Okay, they will give up anything and everything, just take care of me and go from there. Okay, I can't make any thoughts. I have to talk with X, Y, and Z person. I have to do this. So if you get married, hey, we all become a little bit dependent. um, but they do have the unrealistic preoccupation with fears of being left to take care of themselves. Okay. OCD. No room for flexibility, nothing at all. These are the individuals, they, depending on what levels of stages and all that stuff, okay? Um, yes, I'm type A personality and I have OCD traits. Actually, for me, it has to be CDO, okay? Um, they will count. They will count your steps. They have to, if they come into the house, bad enough, they will lock the door 3 times. Touch something, they have to wash their hands, people cleaning and all that stuff. Usually they do have immaculate houses. Um, Slowly interferes and all that stuff. Oppositional defiant, not a true personality disorder, but I've lumped it into this because, again, the aspect of you can start seeing some of the traits, and it is something that we in the pre-hospital arena deal with. Okay, yes, these kids are crazy. Okay, and all the time, and they just don't care. I mean, there's multiple times that, again, they'll have the oppositional, then they'll have that, antisocial, and they just, yep, I killed them, and okay, because I wanted the Game Boy, they had a lollipop that I wanted, and no, you can't do that, and then they still do it. But the oppositional, they lose their tempers, they argue, fail to obey the rules, and go from there. It's not paranoia if the cappuccino really is out to get you. That would be scary if someone did that to my drink. What? Yeah, no, it is. Yeah. So schizophrenia, okay, characterized psychosis, hallucinations, and delusions. Okay, false beliefs, loss of contact and reality, and then the false perceptions and all that stuff. Okay, that's the trademarks and all that stuff. But from there, it's really they have disorganized speech, flat and affect, cognitive deficits, and then the social dysfunctions. And you can tell someone that's having a schizophrenic breakthrough, okay, just by looking at them. What do they look like? Unkept. Okay. And we can tell patients that as they're improving, they're going away from their schizophrenia. Okay. You can actually just watch them progress. If you did they actually did this when I was a medical student, that they took a picture of an individual that came in where they're tied down, restrained, and fighting to walking out. And it was just every day they got a little bit better, a little bit, their hair was combed, they had makeup on, and all that stuff. So it is. Flat nav fat, again, the motions and all that stuff. Ron Howard's, okay. John Nash, anyone ever seen it? No, good movie. Boys, if you haven't seen it, watch it. Yep. It's a little long and drawn out, all that stuff, but it's perfect classic for the schizophrenics. What they do and potentially will do to you. Okay. Schizophrenia, of course, is not the same as multi-personality disorder. We'll talk about that later. A lot of people have that confusion and all that stuff that it's there. Right. Average onset mid 20s in women, somewhat earlier men. They actually say 18 to 20 for males. They'll have their first breakthrough and all that stuff. Usually they indicate that there's a thought process that there's a double hit. So individuals that are genetically predispositioned for this. There's of course 25% of previous schizophrenics have family members that are schizophrenics, just like bipolar. It's huge and all that stuff. So there's a lot of genetic correlation. Or they were looking at twin relationships, where one twin was schizophrenic and the other twin developed it. So there's again pieces and all that stuff. Do have the aspect of onset, the paraphrenia, which is the childhood onset of schizophrenia, which would be a bad day for everybody. How do they look? They have the positives, negatives, the disorganized, and then the cognitive. Okay, so the positives, the actual loss of reality, the distortions, they get the auditory, visual hallucinations, and all that stuff. Versus the negatives, okay, they lose function, they lose thought, they lose the ability to perform any actions and all that stuff. That is disorganized. Okay, this is this pressured speech, the racing ideas, the tangential thoughts that they a lot of times will have. So they'll go from one thing to the next thing to the next thing. Um, and then of course in the cognition, they can't process. Right. So if they can't process, they have, they think they look at you and you're the demon. Okay. They're having anhedonia. They don't want to do anything. What do we have to do to kind of sort of take care of these people? What's one of the first things? Okay. Yep. So that's really, the aspect going that. Okay. So in order to help them, we have to make sure that we are safe first. Okay. Yep. Get on the good side and all that stuff. Okay. So keeping ourselves between them and the door. Okay. So make sure that we have ways of getting out. Don't ever get caught. If not, it will. Okay. It'll change on you quickly and all that stuff. All right. And then, yes, the CIT training, so the crisis intervention training, it's actually something that might want to get you guys to bring someone over and get that training for you. So, real good training. Sandusky County did it. They sent all their crew members through 40-hour class. You get a little pin and a certificate afterwards. Split personality. Okay. Also called dissociative identity disorder, aka multi-personality disorder, or previously, when Charcot came up with this in France in the 1800s, he called it the hysterical epilepsy, where they actually kind of sort of put patients into, they put them around with enough other people that they are actually having mental illnesses and all that stuff. So you can go to prove and some of the stuff that we do is who we hang out with. Psychological condition caused by many factors, usually childhood trauma and all that stuff. Um, Me, myself, and Irene. Was that right? Was that the one that with Jim Carrey? Yep. Perfect. Sybil? Yeah. Was that the black girl? Oh. Okay. Yeah. Smatiforms. Yeah. So somatoform disorders, a couple different pieces with this. Hypochondrias, your hypochondriacs, the anxiety and fear something's wrong. Where to the point, you can actually have factitious disorders with this, or the conversion disorders. So all those go in. So the conversion disorders is they actually have a real, you know, something medically wrong with them, or they feel that they have something medically wrong. So we'll have patients that will come in, and it's usually neurologic. Okay, can't move the arms, can't move the legs, can't do anything. I mean, can't feel. And I mean, you can go up and I mean, pinch and prod and stab and don't feel anything. Nope, nothing. I mean, it's a, unfortunately sometimes. Yeah. Yep. Versus the factitious, okay? So the fictitious is the Munchausen or Munchausen by proxy. So again, a lot of this is false location. So usually with these individuals, they do something to cause a medical illness because they want something. They want to be the center of attention. These are with the Munchausen by proxy, it's the mother that gives their child, bleach, drinks bleach, or we had one that was, the constant was giving them rat poison, and they had they actually in the one of them was the mother had changed um, the kid's urine, so they would put drops of blood into the kid's urine so that the kid would have procedures and stuff, and so that's Munchausen by proxy. Some component of borderline personality disorders involved with it, because again, they want that, join. They want to have the relationships and going from there. Impulse control. Okay, you may or may not see somebody here with this. Okay. From the perspective of lack of control, okay, intermittent explosive disorders part of this, kleptomanias, people that steal all the time, um, the pyromanias, the young kids that set everything on fire, set themselves, set their friends, or then for your pathologic gaming and all that stuff. So if you have a gaming problem, please call 1-800-589-9966. All right. So the addictions, okay, going down the whole process. So we have the unmet needs, behavioral problems. They want something. They get confused. They get pissed off. They want it. They want it. They want it. They want it. Okay, they feel powerless, and then they explode. Darn it! I want this alcohol. I want that drug. I'm gonna go gambling. I'm gonna do something, and then they go. They do it, and then they go through the guilt all over again. Okay, over and over and over again. All right. Eating disorders. It's all levels of wrong. Okay, just like this picture. Yes, I know it's all levels of wrong, but it is what it is. Okay, so anorexia nervosa. Okay, weight loss jeopardizes health. These are the individuals. They will exercise, exercise, exercise. They eat, 300 calories. They might have a piece of lettuce, a sip of a soup. Oh, I ate too much, and then go from there. A lot of the anorexias, of course, there's definitely a personality disorders linked with it, borderline personality disorders, dependent personality disorders, and all that. So the intense fear of being obese versus the bulimia. The flip side of this is the individuals that they eat and eat and eat, and then they feel guilty, and then they purge. Okay. So this is the eat and purge, eat and purge, eat and purge. Okay. A lot of it is the body images disorders, or the um, can't think of what I'm thinking of. So one of the things to take into consideration when you're talking with bulimics, okay, do good physical examination, look at their teeth, look at the backside of their teeth, the erosion, and then look at their hands, their fingers, and all that stuff. Okay, bite marks, or or they'll have the acid stains on their fingertips and all that. It's difficult to comprehend how insane some people can be, especially when you're insane. Okay. So excite delirium. Okay, so the next few slides and all this stuff. All right, out of control. Okay, can't do anything. Somewhat vague, ill-defined. Don't really know what we have some thought premises and all that stuff, but really wasn't diagnosed until or the actual wasn't came about or recognized until 2009. All right, so 6 years ago when they finally came through. Uh, so what specifically is it? Okay. little bit more than agitation. Okay, it's not the Tasmanian devil. It is that person on the right hand side and all that stuff. All right. Otherwise, excited delirium. Okay, it's sudden, it's unintended, and then it's unexplainable, and ultimately we have a negative autopsy. Okay? We do have pieces that lead up to that we see and we know. So Bell first diagnosed or first described this back in 1849. If you look at the timeline and all that stuff, 40 patients, 30 deaths. He called it the Bell's delirium. And then goes down to the 1980s. Increase in cocaine abusers, body packers having sudden death with that. And of course, 2009 ASAP recognized it, which is the American College of Emergency Physicians, as an actual syndrome. Of course, 2011, 2012, we have the synthetic cathinone, so your bath salts, K2, all the other new synthetic drugs that are coming out. Cocaine is starting to come back again, so we're starting to see a little bit more increase with the excited delirium again, especially with the speedballing where they're mixing the cocaine and the heroin. So we reverse the heroin and it throws them into an excited delirium because of the cocaine. God bless. Statistically, we know it's summer months, high humidities, okay, the high body mass index, which means it's males over females, and then they may or may not have taken something. Mental illnesses, okay, again, most mental illnesses, if you look at the access levels, they have something else. So your schizophrenics that are also taking cocaine, crack, and all that stuff, they smoke something because they want to. You know, from there they become pissed off. Someone says, "Ooh, he was already crazy. Now he's really crazy." Okay, and then there's the whole thing with the police. And there's a lot of videos on YouTube that you can watch that can going through, or I can pull up videos later. Okay. The phase of this, okay, phase one is the hypothermia. They may not always have this. Then they get to the delirium phase, respiratory arrest, and cardiac arrest. So what happens between phase two and phase three? What? Oxygen level drops. Why does the oxygen level drop? Okay. Why are they hyperventilating or the airways closing? So what happens between phase two and phase three? Okay. From who? Who shows up between phase two and phase three? What? The police. Okay, we show up. Okay, but usually the police is a lot of times, and then something bad happens, and that's where they go into a respiratory arrest, and then ultimately go into a cardiac arrest and die. So physical clues: they're naked, they're running wild, they're running in traffic. Okay, the unlimited endurance. Brother was working hospital in South Carolina. Football player for the USC. Okay, had taken something. He was one of the linemen. Literally, from the aspect, stood up with the stretcher on his back. Okay, and walked out of the hospital. Yes. Okay. Have a good day. Okay. And then the violent, bizarre behaviors and all that stuff. Violent towards mirrors. Okay, they don't like mirrors. Anything that's shiny, flashy, and all that stuff. They'll destroy it. They'll break it. Again, the superhuman strength, reduced sense of pain, muscle rigidity, high temperature. Okay, and then they resist before, during, and after the arrest. Okay, psychological clues. Okay, hallucinations, delusions, intense paranoia, scattered thoughts, distracted, changes in emotion, psychotic appearance. Okay, one of the videos that I have, it's the aspect of that they say they just flipped. Okay, yep, he was normal, and then I saw him, and then he just snapped. He flipped, something like that. It's usually where the drug comes in. Okay, communication clues. Okay, pressure speech, screaming. Okay, imaginary people, and then they might have the grunting gurgle sounds, and then the irrational or tangential speech and all that stuff. Boys, what's with the pacifiers? PCP days, but what do we have now? Ecstasy. Okay. So your raves and all that stuff. Okay. So ecstasy will actually can throw you into excited deliriums because you increase your serotonin, and they use the pacifiers because they're hot. They grind their teeth. So the Yep, we're in the teeth and all that stuff. So they'll either pacifiers or baby toys. So they'll chew on the toys. So if you again, clues. If you have someone that's carrying something around and you're here at the casino, and they got that little jaw, are they on something else? And they exactly, and there's no baby. So how do we treat this? All right. Well, we got to take care of the agitation, got to take care of the acidosis and the hyperthermia. All right. So for us as EMTs here, okay, what can we do? What? Not warm. They're already hot. Yep. So cool them down. Sodium bicarb. They can't, as EMTs, give sodium bicarb. Okay, but what can they? What can you guys give? Oxygen. Okay, so give them the oxygen to help with the acidosis. Start the process. Okay. Who else do we want to call? Yes, Ghostbusters is a possibility. I don't think they're going to help us. Doc in the box, police. Okay. TFD. Okay. Getting our ALS friends there who can then give the other medications. Okay, calming them down, making them sleep, and all that stuff. Yes, vitamin H and ketamine. Psychological therapy. When the kid is old enough, he is bringing this to explain why he needs it. All right. So treatments, okay, like everything else, our scene size up, do our primary assessments, a history taken, and secondary assessments, and then reassess. Okay, especially with your people that are excited delirium, what's something that we want to continually reassessing? Oxygen levels, core temperature, respirations, heart rate, BP, something else. They're shaking. What? Level of consciousness. They're shaking. They're fighting all the time. What are they going to be using up? Sugar. Okay. Getting your blood sugars and all that stuff. Right. Scene size up. Okay. Again, like everything else, pay special attention. Okay, to the violent. Okay. Unwanted violent situations without proper police support. Don't go there. Get your friends and all that stuff. Okay. And then wait. Okay. Suicide cases, be alert to hazards. Of course, take into considerations the automobile that's running in closed garages. Do they have that pipe, that piece of plastic that goes from the muffler wrapped around to the car? Is there something else that other chemicals that they took, something like that? So before going in and handling things, the bottle of bleach, which really doesn't do much for you. Okay. Locate the patient. Okay. Of course, like everything else, stay between the patient and the door. Articles, if the patient has a weapon, okay, please put it down, back away, don't turn, and then you can have problems with all that stuff. Of course, other potential medical problems. Okay, if they have, they're fighting, they're had a seizure, then they're fighting you, they're anxious. Do we need to make sure that, do they have medical release bracelets? Does family say? Do we have pill bottles laying around? Is their gun next to them if they're suicidal and all that? And then, of course, the aspect multiple patients. You know, the homicide, suicide, and all that stuff. Primary assessments, like everything else, our life threats, our ABCs, go from there. We should talk about that. Focus history physical, preserve dignity's patient's right, open-ended questions. Okay, that's usually one of the big things that they want. Okay, encourage the patients to talk. Sometimes they just want someone to listen. Okay, that's a lot of times what we do best is just letting them talk. Yes, there's times that they keep going and keep going, especially your schizophrenics. They go tangential thought to the next thing, to the next thing, to the next thing. They're pressured speech, and they're just talking, they're talking, they're talking, they're talking, they're talking, they're talking. Or the borderline personality disorders. You've been there for 30 minutes and the person has not stopped yet. Okay, they can just talk. Coast map. Okay, for dealing with your mental stat, one of the mental status exams and all that stuff. So just quickly, is this the consciousness? Okay, dealing with your orientation. Okay, activity, behavior, movements, speech, thoughts, and then from there, memories. So a lot of times too with the memory, I give them 3 words. I use like using the CAT, so cat apple tree. So my mnemonic cat actually is my cat apple tree. And so to ask them that, tell them those, hey, remember these 3 words, cat apple tree, and then you do the rest of your exam. Hey, what did I tell you? What did I ask? Can they actually remember that? And then from there, do they have affect mood problems? Are they inner feeling, sense problems? And then perception. Do you hear things that people can't? Well, again, going on the aspect, signs and symptoms. Okay, a whole bunch of different things: pressured speech, slow speech, disordered thoughts, flight of ideas, perseveration. Keep going on and on with that. Phobias. Ooh, I don't like that. I don't like that. Actually, I had one person that did not was in the ER was talking about the spider that was on the wall. I'm like going, oh, so you're having delusions? Turn around and literally there was a spider on the wall. So before, okay, if they're saying yes, something like that, check the surroundings, make sure that's what they're talking about. No, you're talking about you're seeing spite. Okay, so yes, for what it's worth and all that stuff. All right. Do they have amnesia, confabulation, which is the aspect of filling gaps? So one of the times the confabulations, what I'll do, I'll hold my fingers up and I'll ask them, so what color is this string? Okay. Or do your teeth itch? Yeah. So no, your teeth can't itch, and then hold your fingers up. What color is the string? They will say, "Oh, that's blue. That's purple." Yeah, it's what? Yeah, yeah. Suicidal patients, again, okay, if they tried it, depending on how far it is, if they actually attempted and all that stuff, rapid recoveries, don't trust those. Oh, I'm fine. I'm fine. I'm fine. Okay, you know, had a patient that came in, that actually hung a piece of rope on a banister, had yanked on it, fell down, and then from there, was like, oh, okay, I don't feel like wanting to kill myself now. And then came in and, no, I'm fine, doc. I can go home. Like, no, I don't think so. Okay. Um, and then, of course, don't challenge the patients to go ahead. I don't believe you. So, no, let's not do that. Violent patients, of course, find out if they have any previous history, watch their body languages, keep yourself between you and them and the door, make sure that you have a way out. Okay. Firm, clear, sometimes this is okay, stop, don't do that, sit down, very direct. And then from there, we'll talk about restraining and all that stuff. Yeah. Behavioral, okay, like everything else, okay, look for the warning signs, okay, peace and all that stuff. Make sure that you know your limitations. Okay. Renee's not going to try to fight, a NFL linebacker. Okay. Uh, and how did that do for you? All right. So really from the aspect, make sure that we know our feelings. So a lot of times, like with the borderline personality disorders, okay, when we start talking to these people, what do we feel? We feel nervous. Okay. We feel like we want to rip their heads off. So make so it's the whole aspect of okay, check your feelings at the door. Really go down that piece and understanding. Do we have coping abilities that we can think of? Is there some disturbance when injured or involved? On the with extraordinary events. How do we feel going into this? Okay. Know that emotional injuries, real as physical injuries, go from the aspect, the crisis. Okay, they just don't get better. Suck it up, lollipop. Okay, yes, they might need some help and all that stuff. And then cultural differences. Okay, how do each individual culture, especially since we're getting a large Islamic, the Muslim into the area, that they handle things differently. The Indian, if you're dealing with that differently from who have a very high suicide rate, how they handle things and all that stuff. Techniques. Um, Maintain eye contact again. Be careful with the eye contact depending on the culture that you have. Okay, if you're looking at them and they're shying away and all that stuff, well, if it's a Hispanic, a lot of the Hispanic, cultures, they don't make a lot of eye contact and all that stuff. So you have to be careful. Japanese, same thing. They don't make a lot of the eye contacts. Careful with your quick movements. Don't do anything irrational. Tell them what you're going to do beforehand. I ask these patients all the time, hey, can I listen to your heart and lungs? Yes, okay, no problem. Still been swung at before, even after asking them. Okay, and go from there. Talk to the person, introduce yourself. Okay, ask them their name, build that rapport. And this goes into a lot of the crisis intervention side of things. Just finding out their name, why they're there, what they're doing, and all that stuff. Now, if the person is saying, "Hey, do you see that?" I'm talking to Bob right there. Well, if there's not a Bob, don't go along with that. Okay, you can say, "I understand that you see something." Okay, I don't see Bob. Okay, but don't go along with it and all that stuff. If you need to, okay, a lot of times friends and families, they can come in, they can help. There's a lot of times though that friends and family are not your friends and your family. Okay, they make the situation worse. Okay, so those individuals just have to at times, sorry, you have to go. And I've done that several times before. Okay, don't threaten, don't belittle. Okay, the aspect of you might be there for a while, so bring a sandwich and all that stuff. Have your pillow and prepared to give some hugs and all that stuff. Okay? Don't force, but if you have to force, you have to force. Okay? Encourage. Okay? Get rid of the crowds upstairs. I know that's always a possibility that you're gonna have a lot of people. Ooh, we got you know 15 firefighters, and what does everyone always want to do? Stay there and look and gawk. Okay? So remember too, also from the aspect that we also do, we have a HIPAA. Okay? We still have HIPAA compliance and all that stuff for these patients. So we have to protect them, get them out of that area, put sheets up, push people away, and all that stuff. Okay. So the restatements, okay, versus the redirecting. I have become a master at redirecting and all that stuff. Okay, really, they're going down. This is your some of the tangential thoughts, your borderline personalities. They're just taking you down a rabbit hole that you don't want to go down, and then literally it's like going, oh, and what about such and such and such? Okay, that's the redirecting versus the restating is giving them back. So you feel bad because this, and this. Okay, which goes into some of the metacognition that we deal with, or the actual listening, doing that the active listening portion of our examinations. Management, okay, like everything else, okay, you can't help the person if you get injured, okay. The unfortunate, like the police officer that the other day in Florida, bystander or passerby shot and killed the person, okay. Don't get yourself in that situation of being beaten by somebody. Okay, do what you need to do to get out of there. Call the patient. They'll never leave them alone. They've had numerous situations where person suicidal had problems. This is usually in jails or something like that. They walk out, the police go out, they go get something else, they call 911, they come back in, and the person's hanging. Right? So once they become, that they make those things, don't let them be by themselves, especially for the suicidals. And then appropriate transports and all that stuff. Want to make sure that they're not hypoglycemic and hypoxic. And then, of course, the other way, specifically when we get in our excited deliriums, keeping them calm, cooling them down, and then giving them hydration and all that stuff. Hey, I think he just moved. Add one more. Okay. Restraining. Okay. Whole purpose of restraining is purely to protect you and them. Okay. And then, of course, other patients and all that stuff or other individuals. Okay. Two different ways that we can restrain, either physically or chemically. Okay. Which one is better? What? Okay. Physical, potentially. Okay. Depends on which way you want to go. I mean, if it's just simple stuff that you can restrain him. If it's a little kid, I do this with my little 3-year-old all the time. When he gets mad, I just hold him. Okay. I'm physically restraining. I, what? Yeah. I sit on his legs and all that stuff, so that doesn't help. Or I just swaddle him. Okay. Thank you. All right. So the physical restraints and all. So just really go down that path of yes. Sometimes you can just get by enough where you physically again hold my kid. He stops down. He calms down. He gets up. Goes back playing again. All right. Sometimes they get to the point in time where physical restraints is not enough, and you need your ALS friends to come in and snow them. Physical, make every effort to avoid injuring the patient. Use soft restraints as if possible. Okay. Harder restraints only necessary. If you do have to get the law enforcement involved and then using metal restraints, okay, they have to be there for any metal restraints and all that stuff. All right. Know the plan. Make sure everyone has the same thing. Okay. Everyone's on board with the plan. Again, securing stretcher straps, waist. If they're spitting at you, surgical mask, or even just put a non-rebreather on their face. That way they can kind of sort of protect them. And then once they're restrained, once they go into it, they don't come out. Okay, not until they get to the emergency room or some other place. Nope. Yeah, exactly. Okay. Remember, reasonable force. Okay. It's from the aspect it should never be punitive in nature. Right? We're there just really to stop them from hurting themselves and hurting other people. Okay? How do we do it? Like everything else, okay? Multiple people. Okay? Don't go in alone. One of the best situations that I had when I was working in the ER several years ago, I wish I had popcorn with it. Small. I mean, she's probably 100, 110 pounds. She was on something. She had 4 police officers, 200 pounds, and she was kicking their butt. Literally, I mean, I was like, "Where's the popcorn? This is great." Um, so it depends on what they're. I mean, they can have again going that the whole, the aspect of the superhuman strength. So here, 5 people for each one limb. Some will have a fifth person that actually will on one of the other slides where they're actually the aspect of with the stretcher where they sit down and hold onto the stretcher, and then the top person holding the heads. And then if you have your paramedic friends that can actually sedate them, if you get to this point, sedate the bejeebers out of them. Right? Team leader grabs the head, different ways of doing that. One of the tricks that I do, if I'm in this situation and the person's on the ground, all that I do is I put their head between my knees. Okay, no, they cannot bite you. Okay, and if you want to stop them from lifting their head up, just put your fist right on their forehead. They can't lift up. Okay, Zach Miramontes, I did this to 3, 4 months ago. In Danbury that we were playing. This might have been longer than that. He he could not lift his head, which means he couldn't lift up his shoulders, just by just that simple, locking him down. Versus hold him like that, I think hold him here, the potential of it sliding down into their neck, cutting them, and all that. And we don't have, some of us don't have a lot of upper body strength, so it's just them fighting. They can't, block your knees. Um, just holding the knees if you hold the top part, and to do this a lot of times to kids if they're kicking or something like that. Just putting your hand again straight down above their kneecap. They can't move that knee, which takes out the hip and all that stuff. This was again one of the other different trainings. So you have the two people, and then from there the providers kind of sort of sitting across the stretcher and all that stuff, sitting on the knees and locking them down until they get the person, restrained down and all that stuff. The ideal situation, okay, for our patients, okay, one up, one down, okay. You put them both down. What can they do? Yep, they can lift themselves up. One up, one down. They can't lift themselves up. They can't get up. They can't do anything. Strap across the waist, and then of course the strap across the chest at minimum, or sorry, across the knees and across the waist, and then you can do something across the knees, waist, chest. And when that doesn't work, okay, getting into the chemical side of it. So as us as EMTs and EMS providers, really going down the piece of getting them here, okay, and sedating them down. Basic premises, okay. Chemical restraints used to increase patient safety, facilitate medical care, when physical restraints. So a lot of these individuals, when they're struggling and struggling and struggling, what are they doing? Burning energy. They're increasing rapidly. They're revving up their heart rate. Okay. And remember with the excited delirium, what's phase one? That's the hypothermia. So they become hot. Okay. So they get the hypothermia as the phase one, and then go from there. So the advantages of it, of course, it's really, stopping the violent behavior, reduces the necessary need for physical restraints, and allows for good assessments and all that stuff. So yes, duct tape, first aid, your choice. I don't care. Like everything else, if we sedate somebody, okay, if we give them enough medication, what do they stop doing? Okay, that might be a bad thing. Okay, yes, these individuals might be plastic deficient. Okay, so sometimes plastic through the between the vocal cords is a good thing. Yes, you can breathe for them. Yep, yeah, exactly. Some of them they have the increased effect of getting CNS depressants. So the building on they're already getting some Geodon, and then they give something else, and then they build up, build up, build up. Of course, some of the antipsychotic medications that we give, like Haldol, has the potential of their QT prolongation. So make sure we do EKGs and all that stuff. Not here, but when you're in Fulton County, I can't. Yeah, I don't have $30,000. Thank you. Yeah, no, can't afford that. Um, so again, in the ER, a lot of times we just put them in chemical restraint, and then as they wake up, we pull them out because they're feeling a lot better after that. Definitely calming them down and going from there. Okay. Exact degrees depends on the situation and clinical needs. Okay. Physical strengths with chemical strengths go from there. Again, like everything else, really remember, okay, make them sleep. Okay. Anything that you have to do to make them sleep. My drug of choice is called a B52. It is Benadryl, Versed, and Haldol. So, yep. So I do between 25 and 50 milligrams. So that's the B50. 50 of Benadryl, then 2 of Versed, and then you can do the 5 of Haldol on top of that. It's a good combo. It's a great combo. Yep, the B52. So my nurses all the time they'll look. I just 52 B go, and yeah, and then they ask how much do you want to give. Oh, okay, whatever. I've actually had one patient before I gave him B52, and in 10 minutes, 15 minutes later, was still awake and kicking. So, yeah. So they got the nice hefty dose of 4 milligram per kilogram of ketamine. They were out in 5 minutes. Yeah, it's wonderful.